Well, thank you everybody for joining. First, I will tell you who I am because I don't think a lot of you know me, but my name is Melle Spruit. I'm a gynecologist in training in the Netherlands, and last couple of years I've done some research into chronic pelvic pain in women, and especially also looking into overactivity and treatment. Today, I will talk to you, or I will explain you something about chronic pelvic pain in women and the impact it has on life. I will talk to you about our first article that is our systematic review meta-analysis, because before we started our study, we wanted to know what there was already, uh, known into or known in the literature. Afterwards, I will discuss our randomized controlled trial, and also part of our trial was to look into patients' expectations. So that will be the next part. And of course, I will talk to you guys about the future perspective in managing chronic pelvic pain. So what should you do, and maybe also what not to do. To start with understanding chronic pelvic pain in women, I think you all, most of you attending today are likely having patients with chronic pelvic pain, see that in daily practice. But chronic pelvic pain is very common, and it affects approximately 15% of the women worldwide. So that is a lot of women, and it's very complex because it's multifactorial. It has impact on physical health, emotional well-being, social functioning. So it's a very important subject, but it's not understood very well and not treated very well on this day. But first of all, like chronic pain, how does it work? I always explain to my patients or to my colleagues with chronic pain. There is a moment of pain, so it could be an infection or it could be something else. But because of the pain, you have a muscle contraction. And I always tell them or explain them with shoulder pain, because when people have pain in their shoulder, they will contract their shoulder and you will see them pulling their shoulder up. So you see that if somebody's walking in the street with a shoulder high up, you think, oh, that person has pain in their shoulder. The muscle contraction also has impact on the circulation, because it reduces the circulation in the muscle over there. It causes muscle inflammation, it causes tissue damage, and with all those things that happen, you also get a lowering of the threshold of your pain. So that's peripheral and central sensitization. So because of the pain, because of the muscle tension, because of reduced circulation and everything, your threshold for pain lowers. So you need a lower stimulus to get the same perception of pain. And then you get into a vicious circle, like you see here on the screen, that continues. Because of the threshold lowering, you get pain quicker, and you keep this circle intact. However, this is a very physical. This is all the physical part of chronic pain. But I think everybody who's here today also knows that chronic pain is not always only physical, because right now we also know that we have the biophysical social model, which focuses on the interplay actually of the physical part, but also the physiological part and the social factors, because we know that the social support you have, the economical troubles you maybe have, financial barriers, but also how you cope yourself, your own coping strategies, emotional stress, trouble in your relationships. Well, you can name it, and it has influence on how you can cope with your pain. So, of course, today we will focus mainly on the physical part, but I think it's important to know that the biophysical social model is very important to keep in mind, that it's not only a physical problem, it's also how you cope with it, and that's not always only a physical thing. But when you do research, you have to focus on one part, and we did focus on the physical part of the chronic pain. And right now, also the treatment of chronic pain and chronic pelvic pain for us is mainly physical, because it involves manual therapy with a pelvic floor physical therapist giving biofeedback training, stretching, relaxation techniques, all to reduce muscle tension and improve coordination and elevate pain. But often we see that women, it's not effective in all women, unfortunately, and we need other treatments to help these women. Right now in the Netherlands, these women, so they first go to the pelvic floor physical therapist, and afterwards they often are sent to the gynecologist, and we see them in a multidisciplinary team. But not every hospital has a multidisciplinary team for chronic pelvic pain. There are only some specialized hospitals, but also these hospitals are struggling with treatment. What would be the best treatment for their patients? So one treatment we are focusing on today is Botox, botulinum toxin A. I think a lot of you know Botox from the cosmetic part, but what does Botox do? It reduces it leads to muscle relaxation. So when you inject Botox into a muscle, it causes muscle relaxation by blocking the release of acetylcholine in the muscle. So what we thought with Botox, you can see it right on the screen right here, is we wanted to break the vicious circle. So we want to break the vicious circle by stopping the muscle contraction. So Botox is perfect in doing that, and it works for 3 to 6 months. So that was also great, because if you have muscle reduction, or if your muscle is relaxing all the time, that's also of course not functional in your pelvic floor, because you need your pelvic muscles for stabilization and everything. But right now we just wanted to break the vicious circle. So for a short while, 3 to 6 months, we reduce the muscle tension, and we hope by that also reducing the pain. In recent studies, we also know that Botox not only causes muscle relaxation, but it also helps with the perception of pain. So what I've told you was, because of the tension and because of the reduced circulation and the muscle inflammation, you will get the peripheral and central sensitization. So you will get the threshold for pain that's lowering. The lowering of the threshold of pain is because of the release of neuropeptides. It's, for example, glutamate or substance P, and it all causes that the threshold of pain is lowering. By inhibiting the release of those neuropeptides, we can normalize or stabilize this threshold. So Botox is not only working by muscle relaxation, but we think from the recent studies also that it reduces the hyperalgesia, so it stabilizes the pain threshold also. So that would be great if this was our thought prior to our studies. So that would be great if by giving injections of BTA, we could disrupt this vicious circle. But to better understand what BTA is doing, and to really know what we're investigating with our studies, we also wanted to measure, or wanted to be able to measure, the activity of the muscles. So our thought was, okay, by reducing the muscle contraction, we improve the pain, but we really want to also objectify that. And we did that with the Maple. I think everybody could understand, because this webinar is organized with Maple, with all know. But the Maple, I think everybody knows Maple, but the Maple, we use a probe with 24 sensors that is measuring the activity of the muscles in the pelvic floor. So what we did was, throughout the whole study, so at baseline, but also at every follow-up visit, we looked into the muscle activity of our participants after treatment, and thereby we could also see if the pain had any connection with the muscle activity. So that was this was our thought prior to our studies. But before conducting, or I don't know if anybody has a question about this. I think this was maybe something you guys already knew, but I don't know if there are any questions. I don't see any hands right now. So then I will go on to our first study, and that is our systematic. Oh, I see one hand. Sorry.
Melle, there's one question.
Yeah.
From Simona. Go ahead, Simona, if you have some questions. Could the probe be sterilized?
Well, oh yeah, Onne, you can also answer that one, but
yeah, sure. It's not possible to sterilize the probe, and that has to do with the electrodes which are in the probe, the 24 electrodes. Because when you would like to sterilize it, this will definitely damage the technique inside the probe. So that's not possible.
In our, I will explain it later, but in our study, every participant got their own probe. So it was, our study provided that for all our participants. So everybody had their own.
Yeah, it's a single patient, but multiple use probe, yes.
Yeah, so only the probe. So the whole system, our pelvic floor physical therapist, they of course have the system you need to do the analysis, but the probe itself was only for one participant. Yes. So our systematic review, we did that before setting up our randomized controlled trial to have a clear understanding of the evidence in the literature. And we did this in 2021 to see what literature there was already there and what, if there were any gaps in the research and whether it was a good idea to do a randomized controlled trial. What I said, we did a systematic review and made the analysis in 2021, and after identifying articles through multiple databases like PubMed, Embase, Cochrane, and everything. Eventually, we ended up with 8 studies, and these are the studies we included in our research. What you can see is there were 2 randomized controlled trials, one from 2006 and one from 2019. So by Abbott and by Desi, both studies included 59 or 60 participants, and they also looked at, of course, the Botox treatment and pain and quality of life. What you can see in the other studies that the dose of the Botox is very different in all studies. I don't know if you can see my pointer, but Jarvis et al., they used only 40 units of Botox. But Morrissey et al., they used up to 300 units of Botox. So what you can see is there are some studies, some retrospective studies, some prospective studies, and 2 randomized controlled trials. But everybody is doing something different with the dose, but everybody was also doing something different with the amount of injections they did in the pelvic floor. So we had to really manage that into in this systematic review. All studies had a follow-up between 12 and 26 weeks, and a total of patients. We almost included 300 participants in our systematic review. So also, sorry, what you can also see is I didn't put it on the screen here, but every study looked into a pain score, so a FAS score, but one study did it with a FAS score from 0 to 10, and other studies did it with a score of 0 to 100. So to be able to put that into one analysis, we had to use the standardized mean difference. That's always a little bit difficult to interpret. So I will talk you guys through it. But these are the results. the forest plots of our non-menstrual pelvic pain. So all studies looked, you can see here on the left, so 6 studies looked into non-menstrual pelvic pain with all different lengths of follow-up. And we've looked at 2 to 6 weeks, 12 weeks, and 26 weeks post-BTA treatment. And what you can see here is you always look, we've looked at the random effects model. And what you can see is after 2 to 6 weeks, there was not a significant difference between baseline and the non-menstrual pelvic pain score 2 to 6 weeks post-Botox treatment, because you see that it's still it's hitting the line. So you know that this is not significant. However, at 12 weeks and 26 weeks, we have a significant improvement in pain scores between baseline and the follow-up moment. But you see that the amount of studies we were able to include gets less, because there were 6 at 4 weeks or 2 to 6 post-BTA treatment. Only 4 studies were included 12 weeks post-BTA treatment, and only 3 studies were included 26 weeks post-BTA treatment. What we can see here in these forest plots is that there is a significant difference, but how big is that difference? You know, is it clinically relevant? That's what you always want to know, and that's not something you can get out of this, out of these results. So what we did was translate the standardized mean difference back to the pain score, and how you can do that is that you have to choose the baseline. So you have to choose the standardized baseline from one of the studies, who's what's the one that is most representable for all studies. So we did that with Nesbitt et al. For the non-menstrual pelvic pain. So what you do then is calculate the difference between baseline and the follow-up moment. So what you can see here is that after 2 to 6 weeks, you see that there's a difference of almost 25 points on a scale of 0 to 100. However, this was not significant. So what we can see here is that there was a difference at 2 to 6 weeks, but it was not a significant difference. However, at 12 weeks, there was a significant difference. We saw that in the last slide, of almost 13 points on a scale of 0 to 100. So that means if prior to treatment a participant had a pain score of 60, it now was reduced to 47. And this is all compared to baseline. And at 24 to 26 weeks, there was an improvement of 17 points compared to baseline. So from 60 to 43. So that was for the non-menstrual pelvic pain. So there was a significant difference, but you can doubt if a difference of 10, 15 on a scale of 0 to 100 is clinically relevant in these patients. Then we've also looked at dyspareunia, because that's also a complaint we see a lot in these patients. And that was significant at 26 weeks. But you can also see again that this is again compared to baseline. So compared to baseline, there was an improvement of 13 points. Again, the question is this significant? Is this clinically relevant? So what we can conclude from our systematic review is that Botox may reduce pelvic floor muscle tone, but of course you need better studies and standardized protocols to really be able to analyze if Botox is a good treatment in chronic pelvic pain patients. Also, I haven't shown you the results, but there was also a potential improvement in quality of life after BTA treatment. But only 2 studies had a control group. Of course, that were the studies with the randomized controlled trials. And if you look at the randomized controlled trials separately, so Desi et al. And Abbott et al., they did not find a significant difference in quality of life, but also not in pain between the control groups and the Botox group. So the question is, does it really work? But we thought, based on these results, there was an opening for us with a good protocol, with a bigger sample size, to really see if Botox treatment is, well, a good treatment for women with chronic pelvic pain, because there was a big need for a new treatment. I don't know if after hearing our first study, people have questions about our systematic review. I do not see any hands.
No questions.
Then I think this was pretty clear. So after finishing our systematic review, we conducted our randomized controlled trial. We did that with a whole team of gynecologists throughout the Netherlands. And it was, what I said, a randomized controlled trial. It was double blind, and we did it in 5 different hospitals in the Netherlands. So I was working from Sint Antonius Hospital and Radboud Hospital, and also Isala Hospital, Amphi Hospital, and a women's health clinic, Coryllion, were participating in our study. It's good to know that Radboud Hospital in the Netherlands is a 3rd-line hospital, so it's an academic hospital. So thereby we also had, we thought we had all the participants and all the different kinds of populations we needed for this study. What you maybe see is that we started in January 2020, and I think you all know what happened in March 2020, because COVID hit back then. So that was unfortunate for us, well, for the whole world of course, but also for our study, because we've only included I think 6 participants in January, and then we had to stop our study for a couple of months because of Corona. Luckily, after the summer, we were able to start up the study again, and also include patients in the other hospitals. What we did in our study was we gave 100 units of Botox. It was difficult to choose or to really think what would be the best dose, because what you saw in our systematic review, was really a variety of doses that was used in prior studies. But well, we ended up with 100 units of Botox or a placebo injection, and because right now the first-line therapy is pelvic floor physical therapy, we had all patients also go to the pelvic floor physical therapist. So at the start, people got a measurement of maple at the pelvic floor physical therapist, and then at every follow-up visit, participant went to the pelvic floor physical therapist to really get good coordination of the pelvic floor, like really re-educate them with to really use their pelvic floor muscles in a good way this time. And our sample size was 49 or 94 participants. So we included 94 participants, with 47 participants getting the Botox treatment and 47 participants getting the placebo treatment. Participants had to be at least 16 years old, and of course had to have chronic pelvic pain. Because of the injection, it was necessary that we could do a vaginal examination with one finger, because of I will show you the places we did the injection a couple of slides further, but we had to do it vaginally, so a vaginal examination with one finger had to be possible. And patients had to have previous physical therapy with a registered pelvic floor therapist for at least 6 months. Because we used the pelvic floor physical therapy within our study protocol, we didn't want participants who never had that before. So at least 6 months with a registered pelvic floor physical therapist, then they were allowed in our study. Well, you can imagine that people who were pregnant or lactating were not allowed in the study, or people who had an allergy or known hypersensitivity to BTA were not able to join our study. And of course, if people prior to the study already had an injection into the pelvic floor with Botox, they were also not allowed into the study. Well, a short summary of our study. At inclusion, what I said is before inclusion, participant went to the physical therapist for a baseline MAPLE measurement, and we had a bunch of validated questionnaires. I will show them later. They had to answer prior to the study, and then at the first visit they got either the BTA treatment or the placebo injection. And then after 4 weeks, 8 weeks, 12 weeks, and 26 weeks, they went back to the pelvic floor physical therapist for re-education of the pelvic floor and the MAPLE measurement. And then at the end, we've looked at pain, but also at the at the patient global impression of improvement. But I will talk to you about that later. Then where did we do the injection? So we had a maximum of 6 injection sites, and there was 3 on both sides. So we did the injection in the pubococcygis or the puborectalis of the levator ani muscle. And the gynecologist was the one who decided where the injection would be given. So based on palpation of the muscles, but also based on the MAPLE measurement prior to the study. So we got the MAPLE measurements from the pelvic floor physical therapist. The gynecologist decided where to do the injection. So it was possible that the injections were only given on one side, for example, of the pelvic floor, but also it was possible that they got it on all 6 places of the pelvic floor. But that was up to the gynecologist. So some participants got 100 units of Botox all on the right side, and some got them divided over the 6 spots in the pelvic floor. And like I mentioned previously, we used the MAPLE to really see what we did to the pelvic floor actually. So what's the reaction of the pelvic floor muscles? What does the activity of the pelvic floor do after after Botox treatment? And what you can see here is that the 24 probes are all corresponding with some part of the pelvic floor. And the 2 muscle groups we did the injection into was the puborectal, of course, and the pubococcygis. And there was these parts in the middle of the MAPLE. So that were the parts we looked mainly to. But of course, the pelvic floor is it's all connected to each other. So we looked at the whole pelvic floor. But it's good to know that these parts in the middle we did the injection into. So we've looked at the FAS score, a score of 0 to 10 at 26 weeks follow-up, and our primary outcome was a 33% decrease in pain score at 26 weeks. So that means that if participants had a pain score of 6 at baseline, we wanted them to have at least a pain score of 4 at 26 weeks follow-up. And moreover, we had a second primary outcome, and that was the patient global impression of improvement, so the PGII. And we wanted to have them to have a PGII of very much better or much better at 26 weeks follow-up. I don't know if everybody knows the PGII, but that's a scale of 7. So it goes from 1 is very much better, 2 is much better, 3 is a little better, 4 is the same, so no improvement, 5 is a little worse, 6 is much worse, and 7 is very much worse. So it's a scale of 7, and we wanted them to have either 1 or a 2 on that scale at 26 weeks follow-up. And what I said, we did a lot of questionnaires. So we also looked into the quality of life in pelvic floor function, but also we had the HOTS for the depression scale, for example, and sexual function questionnaires. And we've looked at the maple measurement at all follow-up moments. So if you look at our two groups, so we had the Botox group and the placebo group. In both groups, we included 47 participants, and they had a age around 46 years old. And of course, it was all blinded, so it was all randomized. So you can see that there are no differences between groups. So we had almost the same amount multiparis, or we had the same amount multiparis women. We had the same amount postmenopausal women, and the average pain was in one group, in the BTA group, was 6.4 at baseline and 6.5 in the placebo group. So there was no significant difference between groups. And what you can see is that the biggest part of both groups had chronic pelvic pain for at least 3 years. So in both groups, 73 and 74% of the participants had complaints for longer than 3 years, and it went up to more than 20 years of pain. So these are our two primary outcomes. So we wanted a 33% pain reduction at 26 weeks follow-up. And you can see on the left side that the results, the left one is the Botox. So we had 15 participants having a 33% reduction in pain after 26 weeks in the Botox group, but we also had 9 participants in the placebo group, so that was 20%, with a reduction of 33% after 26 weeks. So there was no significant difference between groups. What we also saw is that when you look at all participants who received Botox, there was a 0.8 reduction or 0.8 point reduction at 26 weeks. So that's almost 1 point. It was significant if you only look at the BTA group, but you can also think about the clinical relevance of it. And also the placebo group had almost 1 point reduction after 26 weeks. So there was no difference between groups, but within the group there was a slight difference, but you can think about the clinical relevance of that. And what is interesting is that even though 15% of the women in the Botox group had, 15 women in the Botox group had a pain reduction of 33%, only 8 women thought it was going better or much better or very much better with their complaints or with their pain. So what we see is that only the pain reduction is not really corresponding with the impression of improvement patients give to the improvement. And you can also see is that the impression of improvement between the Botox group was the same as the placebo group. So in both groups, 8 participants thought their improvement was much better or very much better. Of course, there's no difference between groups then. But so these are the numbers for our primary outcome. But if you look at that we did a mixed models analysis. And if you put that in the figure, you can see here the average pain in the past 4 weeks. So you can see at baseline, both groups started 6.5 and 6.4 pain score. And you can see that the BTA group is decreasing a bit, but you can see this goes from 6.5 to 5.1. But you can see that the placebo group is also decreasing a bit and that there's no significant difference. But I show you this because of this figure, and that's the figure of the maple resting activity. So we've looked at the resting activity of the pelvic floor muscles, and what you can see that at baseline, the pelvic floor resting activity is between 3.5 and 4. And you can see that immediately after Botox treatment, so 4 weeks after, you can see a a very clear decrease of the resting activity after Botox treatment. And you can also see that at 12 weeks, it's already going back to normal a little bit. I told you guys in the beginning that Botox works for approximately 3 to 6 months. Well, you can see at 26 weeks, so that's 6 months, it's not totally back to normal, but you can see at 12 weeks, so at 3 months, you can see it going up again already, the resting activity. However, you can also see, if you look at those two figures, that even though we were able to really reduce the resting activity in the pelvic floor muscles, that was not corresponding with the same pain reduction we would really like to have had at 26 weeks or 12 weeks post-treatment. So based on, and we of course also looked at the quality of life, but that was all not significant, unfortunately. So based on our study, there is an absence of difference between the group in the average pain score and also in the patient global impression of improvement. So we do not support the standardized use of BTA treatment in managing chronic pelvic pain in women. And we also did not find a real correlation between pain reduction and muscle resting activity measured by MAPLE. So what our advice after our study was that it highlights the importance of individualized and multidisciplinary treatment approaches in these women, but not the standardized use of BTA treatment. There were no safety concerns. So we've also looked, of course, into bleeding or infection or incontinence of feces or incontinence of urine, but we did not see that. So there are no safety concerns with this treatment. However, it also did not work for the big group for, the treatment of chronic pelvic pain. I don't know if there are any questions about this. I do not see any hands, so I will go on. So what we know now is that by using BTA treatment, we are able to really reduce the muscle tone, so really reduce the muscle activity. However, we do not know if we also influence the peripheral and central sensitization with that, but that was what we thought prior to the study, of course. But what we also talked about at the beginning of this webinar was the biopsychosocial model, and I think that's just very important in chronic pelvic pain. So we try to really focus on one thing because that's what you need to do in research, but I think in chronic pelvic pain management, it's just too important to look at the bigger picture and also look into all the other factors that influence chronic pain and the management of chronic pain. So that's why we also said in our randomized controlled trial that the multidisciplinary approach was the most important one. So not only the physical part, but also the part with the psychological part and everything around it and the coping. But what we tried in our study was also to see if we were able to put a little bit of this into. So what we can say now is that there is that patients' pre-treatment expectations impact their outcomes and impact the outcome of chronic pelvic pain. However, additional research is needed to further understand the determinants of patients' expectations and their pathways through which they influence outcomes. So because there are not yet really standardized questionnaires for this, we cannot say how big the impact is, but when we look at our research, we think there is an influence of the pre-treatment expectations onto into your treatment outcome. So moving on, future perspectives. What we know now is that concluding everything, is that BTA treatment does reduce muscle tension for at least 3 to 6 months. However, it does not lead to a clinically relevant reduction in pain. And our last study, so the study focusing on patient pre-treatment expectations, I think underlines the importance of our biopsychosocial model, and that there are a lot of factors have influencing how you manage chronic pelvic pain. So every patient is different, and every patient needs a different approach to manage the pain. What we would love to do in the future is, or what we're doing now actually, is we just finished our analysis of our long-term follow-up. So all participants were followed for 1 year. That's our long-term follow-up. So we will come with these results, I hope, in a couple of months. And also we are looking into our MAPLE results, because I only showed you the MAPLE results of our resting activity, but we also had way more measurements with our MAPLE. So right now, Ana dos Santos is looking into she's a pelvic floor physical therapist, and she's looking into all the MAPLE data we have to see if we can learn more from that. And what we are, as a group, as a study group, we are really interested in finding the subgroup in women that really benefit from from the BTA treatment, because we see in our randomized controlled trial that there is a group of women that really reacts very well to the BTA treatment. However, in the big group, so in the 94 participants, we do not see that. But there is a group, I really believe that there is a group of women who we can really help with the BTA treatment. We only have to figure out which group that is. So that will be what we will focus on in the future. But right now, what should we do with the women with chronic pelvic pain? And I've mentioned it a couple of times, but I really think it's the most important thing is that we have that you have a team in your hospital or team in your clinic to really help these patients, because I think it's multifactorial, and we need multiple healthcare providers together to really help these patients. And unfortunately, I cannot tell you right now that it's a good idea to give everybody the Botox treatment. But I hope in the future that we as a team can find a group of women who really benefit from this BTA treatment, and who can we really help. So that's it, I think, for my part. I don't know if there are any questions.